This is something that we part of the student organization, the OMA student organization, and we try to do something like this maybe 2 or 3 times a term. And James is our guinea pig, and we'll start. Oh, I see. You know where you're at now. Okay. So he's going to talk about channel theory, as we promised, and I got no idea what he has planned for us, no clue whatsoever. So we're just going to have fun and enjoy. And we'll probably do an hour theory or something, and then we have snacks in B1. So anybody wants snacks, we got fruits and nuts and stuff over there that you get to family show. Anything? Okay, and we can get started.
Thank you.
So I think that it's a good practice with any conversation with a group like this that we have some agreements that exist for the few hours that we're together. And when you leave this place, you can do wherever you like. But to have a conversation, I think we need to have an agreement on what the topic is going to be about and how we're going to approach it. Right? So I'll come, sure, I'll chat about channel theory. But channel theory, of course, some of the agreements that we need to have is, I feel like channel theory is a means to an end, a means to a therapeutic end. There are going to be lots of ways to approach the conversation of what is the best therapeutic model to help this person or ourselves get to a better place. I tend to talk in ways that seem like, well, this is the way it is, this is the way it should be. And of course that isn't the case. But it is the way that I present things because it's the way that I think about it and it's the way that I practice it. Okay? So when we're having a conversation like this, I want to make sure that we all, when you leave here, I hope that you say, well, that was interesting, and you find a way to use the information in a way that's meaningful to you. Okay? So I think the first thing, we have to, in order to talk about channel theory, we have to first organize our information a little bit. In that we could simplify our medicine into manual therapies, of which needles, gua sha, cupping, any tool that you will use to create a manual effect, and internal stuff, products, nutraceuticals, herbs, food. Those two things are different. They were always different. They were never supposed to be the same thing. Manual medicine worked within the model of the body's particular yet specific organization. And things that we ingest or put inside us are broken down through a chemical pathway that allows for a building. TCM used to talk about it in the sense that manual therapy, like acupuncture, informs channels. Channels then inform systems. Herbs inform systems, which then strengthen channels. They are meant to be used together. That's the way they've always been used. And they make a good system because of that. But they don't do the same thing. So far with me? So, we have to have this as a fundamental agreement that we're not talking about TCM, because what we learn here in school is herbal medicine. We learn acupuncture from an herbal medical protocol. We learn about it as a sign of a set signs of symptoms. And then we come up with a grouping of points which may inform that particular experience. May being the important word. I don't disagree with the learning model. I think you have to start. Channel theory is as we'll get into here in a second, manual medicine is a lot broader, harder to grasp, because it deals with a body in motion that's always changing from one visit to the next. There are parts of them that are same, but there are parts of them that are not the same. So we are not going to talk about the information here in a way that you may be used to. This isn't going to be a conversation where I'm going to use terms like damp heat in the gallbladder or chi stagnation in a particular system. None of that means anything in acupuncture from a channel theoretical point of view. Those are means to describe organ function issues with which we can then prescribe a set of herbs, recommend food, or whatever, to inform change internally. And it's a great model, and it works incredibly well. So I think that that is our big agreement that we need to have, that this conversation isn't going to be about those things. This conversation is going to be about other things. And I'm going to encourage you guys, if you have questions, or you'd like clarification, or you'd like to bring up something that you're interested in, that you try to distinguish in your mind that don't try to unify the two. They are not connected. Okay? All right. So, any good conversation about channel theory has to begin with a fundamental concept of channels go through a very specific and predictable movement with each other. You guys, depending on where you're at in the program here, should all know by heart what that biorhythm is. Do you know what I'm talking about? It's like the tides. Every channel has a low tide and a channel that polarizes it and has a high tide. Lung to large intestine, to stomach, to spleen, to heart, etc., etc., etc. You follow me? In order to really use channel theory as a means of diagnosis, we have to understand that model. We have to know it thoroughly. And we do also have to have a sense of where we're at in the day when we're checking things. Because a channel in high tide, whether it be an excess or deficiency, is going to inform the overall vista of that body's presentation. You with me? Okay. So, all channels have an entry and an exit point. They enter a certain system at their entry point, and then flow into the next system via the exit point. If you guys, for those of you who had me in class, you know that I strongly feel like it's important that you all know the pathways of every single system that you use. When you understand the pathway of the system, you understand all of its potential permutations. And that includes its divergent channel. Where does its lower channel go? There's usually an upper and a lower meeting point to each divergent. Each channel has a divergent channel that has a lower and an upper meeting point. These areas of confluence or meeting with other systems will align for you they will align for you the whys about what a system is doing. For example, if you take the lung channel on the right side, if you look at the lung channel, I'm sure all of you are familiar with its primary channel pathway, from the thumb to the upper part of the chest. And then from lung 1, it descends down through the lung and into the ascending colon, but only on the right side. The left side lung channel descends down through the left lung into the descending colon. So if I want to affect change, maybe somebody's having what we would call a retroflow condition in their descending colon. And it's not my job to put in a prescribed amount of points. It's my job to find out which system is malfunctioning and then correct it. I can use any manner of lung channel points to correct that problem in the descending colon because the channel passes directly into that area. All I have to do is find the channel that's reactive and the points that are going to affect it. Now, I'll show you, we'll have some practice sometime today, perhaps, about how we can then start to get, like, how am I going to figure that stuff out? Well, we'll begin that conversation. But we need to, in order to ask our hands to give us some data, we at least need to know a little bit about what we're asking, what we're looking for. And so, knowing the causeway, that somebody came in and they're saying they're constipated, and okay, their constipation, and I do some palpation on their abdomen, and their descending colon is tight and in spasm. Well, I know what systems run through the descending colon. Where do the channels go? Like, if you don't know anything, if many people will just use large intestine points, because they'll just be like, well, okay, the problem's in the large intestine, so I'm going to use large intestine points. And I'm not going to say that's, this point of the class isn't to say that one thing is better than another thing. Another agreement, I'll add some agreements probably into the last paper here, and then all our agreements will go away. So my innumerable amount of agreements, next one is going to be that my conversation here with you is about efficiency. It's not about rightness. Because the great thing about a body in motion is that everything connects itself to everything else. So can I use large intestine channel points? Theoretically, you could. I would argue that that is potentially not the most efficient means of using points. There are better means to effect a faster change. So when I say, I don't agree with that, please don't take it as, this isn't a conversation of, oh, well, if you use these points, you're wasting everybody's time. It is a conversation about, arguably, I think that this is a more efficient model and this is why. Okay? So, my point in all that was, for your board exams, I understand it is important for you to have a familiarity with, here is a syndrome, and here is a set of points that I think about when you say, you have this particular pattern, and I think about a set of points. Fair enough. Honestly, it's plenty useful. But the next phase of that is much simpler, in my opinion. Meaning that you guys will be able to, someone will come in with a general complaint. Let's say they come in with a complaint we hear all the time. They have back pain. Someone comes in with back pain, and your job initially is to ask a few relevant questions on identifying maybe the quality of the back pain, and then you get into what system is the pain coming from? What's tight? What's loose? What's inflamed? Which brings me up to the next important idea when you're talking about channel theory. Because when you go to touch a channel, you have to be able to, you're looking to identify a few markers. The first thing you need to know about channel theory is you got to know where the channels go. If you don't know where they go, you can't be doing channel theory. Okay? The second thing you need to be kind of conscious of if you're using channel theory as a model for change, is you have to be able to understand some of the core things that you're feeling. A healthy system has a general level of tone to it, meaning that as you get into it, it has some bounce. It's both not too tight, it's not fighting. As you apply some gentle downward pressure, it follows you down. It pushes up against you, but not vigorously. You can put some pressure into it, and then when you let your pressure up, it follows you back. A healthy system has a very specific feel to it. And once you get the sense of what it feels like, it's almost, you can almost see it before you don't even really need to feel it. Healthy systems look healthy. And then you can double check with your fingers. Other common things that you'll run into are, let me think about how to say this. Clinically, when someone comes in and tells you about their problem, all of us make a initial supposition about their problem. Do you guys, what would that supposition be? Someone comes in and says, I have back pain. You hear the problem. Immediately you think to yourself, this is a okay, right. This is an excess or it's a deficiency. All problems are at least broken down in your initial guesswork as this sounds like an excess to me or this sounds like deficiency. We're going to, for channel theory, for herbs, you kind of don't need to go much further than that because the herbs do all of the thinking for you. They are magical in and of themselves. You don't need to be like, well, this is what kind of excess? How is it? Where is it excess? What's an excess? What tissue type is an excess in relationship to what's deficient? Because the herbs are balanced. They'll be like, just use me appropriately and I'll take care of everything for you. We, on the other hand, that doesn't work for acupuncture. We have to know. So when you say this is an excess or it's deficiency, it's an initial, it's almost a way of saying, if I'm right, I should start feeling certain things. So, within a channel system, what does an excess feel like?
Painful with pressure?
What?
Warmth, maybe?
I'd say, Connie, that warm, heat is the only thing that is very specific to an excess condition. All of the others, you can feel in deficiency. Heat and cold are the only two clear, defining sensations that are related to. If someone comes in and says to you, I'm having back pain and they feel really cold, almost in every case it is because of deficiency. We do not live in Alaska. If we did live in Alaska, we may run into what are pathogenically called external invasions of cold that lodge locally in a specific set of tissues. And then that could be called an excess cold type E syndrome. But we don't get those in Texas. It's just not cold enough. And even if somebody does get a localized cold invasion, it's because of the deficiency that they got it there. So cold and heat are your best indicators for, like, here's how we can explain it outside of sort of just TCM model. Someone comes in with back pain, and the area is noticeably inflamed. Red, painful, tight, hot. That is an excess condition. But swollen, tight, painful without the heat, now we have the same pattern based on deficiency. It's only in relationship to the temperature that we find a clear delineation between those two concepts. And here's the example why. Think of, I'm going to use this metaphor a lot in our talk this afternoon. Imagine our bodies as a garden. The garden has many beautiful things growing in it. In one side of the garden, there's a corner over here that you notice the ground is dry, cracked, hard, and nothing is growing anymore. That's what a deficiency looks like. There is no more nutrients in the soil. There's no more water. There's no more nothing there. It's clumped and dry and adhered. And the only way to nourish it is with gradual, steady watering. There's no way to quickly do it. You can't take a fire hose and blast that side of the garden. All it's going to do is excavate that clumpy dirt and blow it over your fence. And then your back's in the next yard. The only way to do it is to put a little bit of work in until you get a general level of hydration back into that tissue. Then you can start to inform it. Then you can start to work it. Then you can start to till it and build it and increase its surface area. You see what I'm saying? Deficiencies are what we see the most. And so often, people just say, well, this is tight and painful, so this is an excess. 9 out of 10 times, it's not. And when you treat it like an excess, it's a lot like treating your back pain with a shovel. Like you go to that part of the dirt and you're like, oh, this just needs to be broken up a little bit. And you're just digging big holes in the back of the garden. It's like, well, that's at best not going to help the matter. So if it's hot and red and painful, reliably, it is inflamed. You treat it like an excess condition. But if all you see is tightness and pain, your initial thought should be, this is the deficiency. And it's a significant deficiency. Because if it's tight and painful and it isn't red and hot, it is just like that metaphor of our garden. There is very little moisture left in the soil. And that is bad. At the end of the day, wellness is about voltage. It's just about power. There's no okay, let me reword. There's no mystery to what it's about. The mystery is that. Like, that is in and of itself an incredible mystery. But we don't need to be like, oh God, my wellness is so complex. It really isn't. It's a garden, and it needs moisture and water and nutrients. And when it has those things, it takes care of itself. When it doesn't, it gets sick and it dies. So how do we fix it? We either clear the flood out, we take things out that are congesting the area, or we add things in that will promote its wellness. It's simple. Voltage, power is the key. And you can very effectively with your hands, get a good sense on systems that are either where they're at in the spectrum of power. Do they have enough power to give to their organ systems so that that system can perform its functional responsibilities? If a channel doesn't have enough power, that system is going to start to prioritize its functions. So, as a review, you must know where the channels go. Second, what was number 2?
Must know where the channels go.
That was number 1.
Oh, okay.
What was number 2?
It says deficiency.
Understand what you're feeling.
Okay, both are right. Both are part of the concept of you have to use your fingers to understand what it is you're feeling. Is it tight? Is it hot? Is it cold? Is it mushy? Is it soggy? How far does it go? Where does it stop? Does it start at the ankle and move up to the knee, and then does everything regulate? Where does it go? Channel theory is a curious model of information gathering. It means that someone comes in with a set of problems and you say, well, man, that's weird. That sounds like, well, I know these systems all work through there and they meet at these pathways, so let's start with those points. And then you start at the points and see, how do they feel? Oh, they're really reactive. Follow the causeways. They're all reactive. Okay, now I know where I have to work on. Systems that are underpowered are not going to perform their functions. Systems that are short-circuiting the area, meaning that they're in excess, are going to create a short and blow the fuse out. And then that's not going to, then that system's underpowered. I mean, it's not going to work either. I stand by my comment that as acupuncturists, we are combined professionals. We are both plumbers and electricians at the same time. We have to integrate in both of those fields. The concepts of how things are built work very well towards what we do. So I'll give you some hands-on practice in a little bit. But the idea is, until you have a sense of being able to, like, okay, I'm going to check something out. I'm going to check this body out. What does it feel like? How do I assess? This channel feels pretty good, and then it starts not feeling good right here. Let's say someone's spleen channel feels good all the way up to their knee. And then at spleen 10, it gets really reactive. What do you do?
Go up the spleen thing.
Go up. Follow the course of the spleen channel. Where does it follow its way all the way up? Through the pelvic floor? Through the groin? I mean, you can go up. Is it hot at spleen 15? Is it reactive there? Oh, it's not reactive there. So where does it go? What's happening? It stops at spleen 12. Okay, so that entire pathway has a problem. And you may not know what it means in that moment, but you should take note of it, because I promise you, people come in all the time and they say, hi, I'm here for my headaches. Okay, cool. You start checking them out. You're like, man, this is all messed up. What's going on in here? And then they're like, oh, yes, God. My whatever's been hurting me for months. But I didn't even want to bring that up. I didn't think you could do anything for that. It's like you will find that the information you gather is very relevant for that body. And they will have forgotten that it was a problem. Or you'll notice things that you write down in your charts, and then 6 months later you see them again, and now they're having problems related to that issue. Channels both tell us where we're at, and they tell us where we're going. And the health of them is a very informative predictor. I have dozens of charts where it says, where I've seen people for years and years and years, and it says constant gallbladder stress, constant gallbladder channel stress, constant gallbladder stress, and then they come in and they're like, yeah, I rushed to the ER last night for had to have my gallbladder removed, or ever since in the last 2 years I've had crazy migraine headaches, or I recently developed a cervical spine issue, or whatever. It's just like, yeah, what did you think I was talking about all those years where I was like, you have to cut it out, you have to change. The stress here is significant. It's going to fail. And when the channel fails, that's it. Then you get a big problem. Okay? So, conceptually understand that your fingers will give you information. I think all of you intuitively would be able to say, you don't need to think too much about what healthy tissue feels like. Healthy tissue feels healthy. And while you may want some words in your head that say, well, healthy tissue, can you characterize it a little bit? Yes, it feels toned. It feels alive. It feels bounced. It feels energetic. It feels responsive. It feels like it can spring into action. That's what healthy tissue, that's what a healthy system feels like. It's conductive. It's powerful. It's a tiger stalking in the woods. You know? And if it's not that, if it doesn't feel like that, it feels like something else that I have my own words to describe, but you guys don't need to have those words. You just need to notice this is a weak system. This is a strong system. This is a system in excess. Okay? So that's the next thing. You need to identify what and where the problems are. Initially, the best thing for you to do is like, you know what? If someone comes in, it's like, hi, nice to meet you. Why are you here today? Okay, sorry, my exam took 1 hour today. You're going to have to come back next week, and I'll give you your treatment. Or you schedule 2.5-hour initials because it takes you a long time to figure it out. It doesn't matter. When you first get into practice, you don't have a preponderance of people to see anyway. So you might as well spend 2.5 hours with the people that you do see. Seriously. Right? Like, well, I don't know what, I'm going to check all your systems. Might as well get the practice. What's it feel like? What's it feel like? Oh, those are all bad. Write them down. What's it feel like? What's it feel like? Oh, those are bad too. I'll write that down. Your patients will participate in the information gathering. They'll be like, stop it, that hurts there. Stop it, that hurts there. Or, that feels weird there. Or, that's really numb. And you're like, okay, that feels numb. That means it hurts. Okay. And as soon as you get that feedback, you start to gather information really quickly. Like, your fingers have a memory of, this means it will probably hurt. I always know what's reactive. It's just about pressure. Like, the more sensitive your fingers get, the more it's like you can just gently touch an area. It's like, this is reactive. And I say, this is reactive here, right? And they're like, no. And I'm like, whoop. Yeah, that's really reactive. And it's not like it's not like I can take lots of places and really press, and it's not reactive. Reactive areas feel bad. And people will tell you, that hurts when you touch it there. You'll be like, okay, that's what that feels like. You will learn for yourself. Don't fret over it. The more time you spend in the clinic, the faster you will get better. If you're not treating people, this isn't something you can learn conceptually. Channel theory is a hands-on practice. The concepts of it are something that you can get initially so that you can fortify your mind with what you're looking for. And certainly, the first step of channel theory should be, before I start treating, I'm going to know the causeway of all systems. Remember our first rule. If you don't know where they go, then it doesn't. You don't even know. How can you assess? It's like, where's the large intestine channel? if you don't know where the channel goes, how can you put your fingers on them and assess strength or weakness? Because you may or may not be in the system. Right? If I come around, it's like, this is really tight here. Large intestine channel is really tight. That's not the large intestine channel. Oh. Like, it's not giving you any good data. You have to know where the pathway is. Which brings up a good point. Remember, channel systems sit in the in-between places of things. They do not, if you're feeling a muscle, if you're like, well, there's the system right here, and you feel like you're putting pressure, like all you're pressing down on is a bone or a muscle, the system may be around there, but that isn't it. Sometimes muscle groups are so tight that you can't get in between them to get to the system below. That is enough of a sign and system, like a sign and symptom of a problem. If I can't even get to the space in between because there's so much swelling and inflammation on the localized connective tissue, then that is a problem. But as a guide, when you're trying to find your way, knowing the general pathway is important, but you have to put your hand, every body is different. And the only way to get good at it is to follow the pathways on as many people as you can practice on. Here's where it is. Here's where it is. It goes between these places. There's, ideally you should learn it in point location. There's no time. In point location, you need to learn what points are. Why do you need to learn what points are? Because he's going to ask you someday where all these points are, and you better worry about them. Ideally, point location should follow channels. You learn where all the channels are first, then you can start. Then you can find points on those channels. You guys are putting points all over the fucking place. It's like, where is that? What point is that? That's large intestine 7. That's on the fucking Sancho channel. What do you think of that? But refinement is something that happens for us always as we practice. All of us, doesn't matter how long we do it. It's like, we refine where it is, where we feel it, where it goes. But we should all have some agreement that the large intestine channel starts here and moves in the in-between spaces along this trajectory. And its points sit, of course, within that trajectory. So, those are all important steps. If you guys are like, I like chant here, I want to use it more. Well, again, today I'll show you some methods to identify, as you put your hands on people, some methods for you to say, this is an unusual response, this is an unusual place. But it still does go back to how comfortable you are with the prerequisite information to using it effectively. Okay? Any questions so far? Go ahead, Andrew.
In terms of your use of channel, in terms of the channel location as used in your practice, what percentage, or rough, I just need a rough idea of the location on the surface of the body. I'm not talking about divergent channels and deep channels, but surface channels, primary and lower channels in, for example, dead mineral cams or something like that. And our curriculum here is actually going to help us to be able to accurately understand where channels tend to be on the body. And you're talking about points versus channels, and
Are you asking, with the information that you have at your disposal currently, is that an accurate means to assess channel pathways?
right.
Yes, absolutely. Absolutely it is. If it says, now, yes, short answer is yes. The longer answer is that, obviously academics and the academic version and the clinical version are not always as intimately connected as we'd like them to be. We'd love to be able to read something and say, well, and here it is in practice, right here, just as it was written. No, that doesn't happen. But it is a good enough guide for you to, say, well, like if I had my druthers, by the time you guys got into clinic here, you would have a period of years where, while you're in there, you would be like, okay, you're treating. I expect that you know the pathways of these systems, and I expect you have a general idea of where the points should go on the pathway. So if you come in and I don't like where you put a point, I should never have a problem with where the trajectory that you put that point on. The large intestine channel is like a gaping wound through the arm. It's huge. It's like a chasm. Like how you can... It's very difficult to miss. And yet it's like that isn't the channel. It's like that's probably measurement-wise where large intestine 8 is, but you're not in the system. And so if you're not in the system, the amount of change you're going to be affected is minimized.
I guess my question,
Go ahead.
follow-up question. Are you talking about rhetorically in the case of like somebody misplacing their long third intestine?
No, I mean that
I mean the actual direct trajectory of this LI channel as it's described is more like the Sandow channel.
No, they're well, they are. I don't know if I'm not trying to draw any association between the large intestine and the Sandow channel.
Okay.
Other than that, they both are chasms through the arm. Not the same one though. Cody.
I know we've talked before, or rather in class, about channels being in between muscle bellies, things like that. You said in the in-between spaces.
Not only through the bellies. Sometimes it can be on the lateral side of the muscle
That's
or the
what I'm
medial
saying.
side of the muscle. It won't be through the belly.
That's what I'm saying, in between the muscle bellies. So, and one particular thing that's always stood out is spleen 10.
Right.
I know that there is a tiny septum that runs through vastus medialis.
That's true.
Is that where you're claiming? Okay.
Well, if you have a sense of the channel system, the spleen channel runs up through an intersecting pathway between these two quadricep muscles. It's very easy to find and feel. They split and fold apart, and the causeway is easy to follow. Spleen 10 is on the causeway. Now, where you may locate your spleen 10, because you're like, I'm supposed to do this, you may find, well, that's not the point, no pun intended. The point is, find the system, split the muscles, come down, and then find around that measurement. And now you're at spleen 10. Spleen 10 does not exist at this location. Spleen 10 exists around that area within a certain reference point to here along the causeway of that system. But if you don't find the system, you shouldn't be locating the points.
So you're saying that it's not located within that muscle belly? Spleen 10. Is that what you're saying?
I'm saying that spleen 10 exists at a relative location to this measurement within this pathway here. And that pathway is very easy for all of you guys to find. Because you'll apply pressure downward, and you'll feel those two parts of the quadriceps go, and it's like, oh, there's the spleen channel. Same thing in the stomach channel. It's on the lateral side and the medial side of whatever this part is called. You guys know all those terms, I don't. Okay? So, the next thing, and maybe the final thing to keep in mind with channel theory, okay, is that, and this is a little bit more, we're starting to get a little foggier, a little less clear. Hopefully I've been immaculately clear thus far. But we're starting to get a little less clear in that inevitably what your purpose is you are both trying to diagnose a problem and formulate an effective means to treat it. Of course, when it comes down to treatment, it's going to vary. There is not a set way to make something better. We should, though, be able to have an agreement on so-and-so came in with this problem, this is what I found. Wow, okay, well that's relevant. Now, how we go about fixing it is going to be related to how I like to work as opposed to how you guys like to work. But no matter what tool you use, wouldn't you agree that you should be able to define and feel a difference in the systems that were originally troublesome? For example, if it was tight and painful, it's less tight and painful. If it was red and inflamed, it was less red and inflamed. That you initiated a process that oftentimes takes 2 or 3 days to fully complete itself. Remember, channels they only cycle, they have a high and a low tide once a day. And so, at the very least, it takes 24 hours to fully process an acupuncture treatment, because if I give you your treatment at 3 p.m., I'm using the resources of your biorhythms at that particular moment, and it's not going to cycle through to full completion for another 24 hours. And arguably, you may need a couple cycles to fully integrate what I started today, provided there's not a preponderance of negative lifestyle variables, which are just going to neutralize everything we started. Right? Like, you came in with sciatica because of a right-sided hip rotation, and then you went and did gymnastics for 2 hours after your treatment. It's like, okay, that's not probably going to be the best plan for your post-treatment therapy. But provided there is none of that, it's going to take a couple days. And so you should always tell people, hey, it's reliable data for how you're feeling is if you feel great, you wake up tomorrow, you get a good night's sleep, oh, I'm feeling much better, much better. It's like if they felt good for the first 3 or 4 days, and then it starts to come back, it gives you data about how you can work with things. But it's an unreasonable expectation for people to get off the table and go, I'm fucking awesome, thank you. It is a reasonable expectation for them to have a shift when they're leaving the clinic, and then a continued acceleration of that shift to some point over the next 2 or 3 days. The tools you use are not important. Use whatever tools you like that are best able to handle the job. If we were to say, but let's classify a few for just clarity's sake. Let's say we're dealing with a genuine excess condition. Which tools that all of us have commonly at our disposal are best used to handle this job? Cups. Cups, scrapers. Certainly so. Yes. Anything else? Objects that bleed, that allow for bleeding therapy. Yeah, certainly. Yeah. Your fingers?
Hands.
Hands. Yeah, totally. Let me ask you guys a question. When tissue is inflamed, what are its electrical Let me ask you a flip question. When tissue is deficient, what are its electrical properties? And okay, if it has low conductivity, what does it also mean it has?
High resistance.
Exactly. Power is always related to this formula. This is called Ohm's law, meaning that if I know any two of these, I can find out the third very easily. But it's related. We're not, this purpose of this gathering is not necessarily to go over this, but it's at least relevant in that, as we just said, deficient tissue is highly resistant but poorly conductive. It's like our garden analogy. It is clumpy and dry. It has poor voltage. It has a minimum amount of current. And it is incredibly resistant to adding. You can't just gently sprinkle the dirt and expect it to hydrate fully, right? It's dry, it's clumped. The amount of steady watering that you're going to need to put into that place to get it to all, first of all, unclump, open up, fully assimilate back into the rest of the soil, that takes time. You have to wear that resistance down. You have to stay at it. You follow me? As the resistance decreases, conductivity increases. Now, on the flip side, channels in excess are like what? What are their electrical correspondences? They have very low resistance and are highly conductive. The importance of that is they're like a vacuum. They draw. Have you guys ever noticed it's like you have an area that's inflamed, and then all of the rest of the system on the area of the inflammation is vacuous. It's weak because the high conductivity of the inflamed area is like a vacuum, drawing resources up from every angle. It's like a whirlpool sucking resources down into it. It has very low resistance. It has high power. It has to be neutralized. You have to draw it away. It's like a collection of water. It's like a puddle in your garden. And the puddle is creating little pathways through the rest of the garden that just allow any water, instead of seeping down locally into the roots, it just channels it across the top into the puddles, making the puddles stronger, making the channels weaker. They're completely different problems, but of course at the end of the day they create the same problem, which is a lack of power in a particular pathway. But the treatment of them is incredibly different. And there's no right. If I had this is the treatment for this, and this is the treatment for this answer, I would, of course, share it with you. But there is no answer like that. It is there. What we do is you just have to work on it. You have to. The concepts, though, are you have to gently water the deficiency, and you have to move the water, the accumulation, away from the excess. What tools you use to do that can be like, for example, one of you guys said cups and gua sha tools. If the medial aspect of my knee along the spleen channel was really inflamed because my meniscus attachment was inflamed, or I had a Baker's cyst or whatever was going on locally that was creating the inflammation. The idea would be, if this is deficiency on either side, that I take my scraper and open up, draw away, up and down into the system. I'm not going to work locally. You don't move a puddle by standing in it. You move a puddle by drawing its resources away. You have to engage the pathway to assimilate the excess. It doesn't mysteriously evaporate. If it's an excess in a system, define the system, find out where the deficiency is, which side. Does it go up and down? Is it just in one direction? And use the body's strengths to move the excess away. This is also where your channel knowledge comes together, because the body is rife with meeting points and access pathways in small vessel channels and collaterals that can be used to draw those accumulations, divert them away so that you don't even need to use the primary channel that's effective. You just use subsequent systems that are relatively healthy that will be able to handle the load easily. Can you use points for that? Of course you can use points. Any point you put in is magnetic. It attracts resources. It attracts power, for sure. So if I have an accumulation of power, and I take a pathway that's easy to get to, and I put a point over here, it's like now I'm creating an attractive force through a relevant system over to this location. You see what I'm saying? So at the end of the day, all our tools can be used for either problem, but the way we use them will be different. And I think that the way that we use our tools, like we said initially, that's going to be specific to who we are, how we conceptualize things, what we like to do, what we're interested in. But we should all have an agreement on the first two. If there was somebody here on the table and they came in and said, I'm here for this problem, and I checked the person out, and I said, this is what I found in their body. This is what I found. All of you should be able to come up here and find that same thing. I'm not talking about pulse either. I'm not even really talking about their tongue. Because while pulse is incredibly subjective, tongue less so, channel problems are very clear-cut. This feels like this. It looks like that. Like, we don't even need to touch it. Just look at it. It looks like that. Wouldn't we all agree it looks like that? And then we touch it, watch what happens. The patient feels it a certain way. We experience it a certain way. It's about as objective of an experience as we have at our disposal diagnostically. And truthfully, we don't need anything else. You don't need to look at their tongue, although it's helpful. You don't need to take their pulses, although it's helpful. They work to kind of combine, summarize, and validate other things that we're feeling. This feels like this looks like this, and all of this is like this. Meh. Okay. It walks like a duck, it walks like a duck. What do you think? Okay, so I think that I'm going to choose. I have purposeful choice right here. Jesse. Jesse, come on up here. So, yeah. How about, yeah, that sounds good. That sounds good. Okay, lay on your back. So, as a good rule of thumb, I think for all of you guys, as a good rule of thumb, when people come in to see you, it is important that you get your hands on them as soon as you can. If you are somebody that is not, I'm not being weird when I say this. If you're not used to touching people, if you feel awkward touching people, if you make them feel awkward touching them, figure out what you're doing and stop it. We practice a medicine that, first of all, it is very, truly hands-on. There are ways, like, you don't always have to touch their skin. You can touch their skin. It doesn't need to be if you feel like, oh, this person's feeling they're uncomfortable already, they're nervous because they just got here, or they're up in front of a classroom of people. You don't necessarily need to be like, well, let's take all your clothes off and check things out. But you still need to feel like everything you do should still have an undercurrent of care, compassion, and sensitivity with it. Alright? It's only something you get from practicing doing it. The next thing that you need to do is, this person here is going to come in. If you've seen them before, if it's the first time you see somebody, oftentimes they come in expecting to talk to you for a little while. As soon as you can get them up here, and they can continue talking to you, the better. Because you will find out, you need to kind of check things while they're talking to you. Is everybody treating in the clinic? Who's not treating? Raise your hand. Okay. So, but you guys have all observed. Okay. So, you guys have all seen or had to give treatments to people, especially here in the student clinic, it happens a lot there, where the person comes in and 45 minutes later they're done talking about their problems. That is not generally the case professionally, thank goodness. People realize that they come in with genuine problems, they'd like them fixed as quickly as possible. It's too much money for them to play around with, hence the reason why they come to the student clinic. But even if somebody has 45 minutes of things to say to me when they come in, as soon as you can get them into this position, because while they're talking, they say, and I'm feeling like this, and then back when I was 14, this happened, and then I did this. As they're telling their story, you're putting pieces together. You're thinking about the system functions, which ones were strained, where those go, and then immediately you start checking. Your hands just go, well, those would have all caused problems through here, and that's going to be, let's see what all that feels like. And then, oh, that all feels fine. And you start ruling things out. So by the time they're done talking, you already have a good idea of like, wow, that was all tight, this was all tight through here, these were all reactive, this all felt fine. And then you can kind of move forward with, okay, this is what I think is going on with what's wrong with you and how I can help and how long that should take. Some people, if you've seen before, you'll be able to kind of like, you'll know where you were at last time. And so you'll be able to immediately come in and check reactive areas that were troublesome last time. You guys may or may not know a lot about abdominal palpation. There are a number of systems. It is not important that you know which system. It isn't even important that you know any system. What is important is that you can use the move points on the abdomen and just check those. If you check stomach 25 and stomach 25 is tight or uncomfortable, what would that lead you to then check? You would definitely want to check the large intestine channel. You would definitely want to check where does it go. It's like, Jessie's stomach 25 is tight, and her channel system up through the quadriceps is tight, and then I get down here and this is all tight. It's like there's something going on in the stomach channel. And I just put it away in my head. I don't know what it means yet. But I know that it means something. I know that it doesn't feel the way it should. You follow me? So you don't need to, the abdomen is an incredibly great place to start with palpation because everything passes through here. All of the meeting points, major meeting points are in the abdomen or on the upper chest and neck. So if you're going to start with palpating, it's very easy to start with like, well, let's start with points here and see how the abdomen feels. Let's check stomach 25. Let's check the stomach channel up and down around the abdomen. Let's check liver 13. Let's check REN 3, REN 6, REN 4, REN 12, CV 17, CV 15. Let's check up under the ribs on both sides. Let's check gallbladder 28. Let's check stomach 30. How does all that feel to me, and how does all that feel to Jessie? Because you guys will be able, with a little practice, like I can tell that this is reactive. This does not feel good. And Jessie says, feels tight. And I'm not pressing hard. The idea is, especially in the abdomen, you can definitely press hard enough to be like, that hurts now, doesn't it? The idea is to be like, yeah, okay, this isn't a relaxed sense of movement through here. Do you know what it means yet? No. And it's not important that you know what it means. I give treatments every day. I have no idea what it was that meant. But I don't need to know what it means to try and find a way to clear it up. I don't know if someone comes in and they're like, I'm here because I'm just taking better care of myself, and I'm taking care of my wellness. And I'm like, okay, none of this side feels fine. This side does feel fine. What does that mean? I don't know, but it's my job to make it better. See what I'm saying? How do I make it better? You just do. There's no answer. There's no secret to that. I don't even know. I can't even give you. I could give you 100 ways that you could try. What's the right way? The one that worked. That's where you learn in clinic. That's the reason you have clinic. Up until this point, your classroom time is about experiencing. It's about knowing that systems go from here to here. These are pathways. These are access points along these pathways. This is what it feels like when this isn't a good feeling. This is a normal feeling. Okay, I got it. Then when you get into clinic, someone comes in and you say, I noticed all of these places that don't feel right. I don't know what that means. And your supervisor says, this is what that means. And you learn from it. That's the trajectory. That's what should happen. If it doesn't always happen, that's okay too. Because at the end of the day, we all have to pave our own path. You guys will get out of school, start practice yourselves, become successful. Hopefully some of you will teach. And then your students, you'll be standing up here saying, well, what I can share with you is the concepts, and I can help inform you towards what it feels like. But the dynamics in a treatment room exist in that present moment only. There's no way to be like, well, I'll just put in stomach 37 on every person that has this. You can, and it'll work some of the time. But remember, the prereqs are the prereqs. You can't even get to the treatment phase if you don't know. When you don't know, what are you going to do? You're going to follow the point prescriptions that you learned for a particular syndrome. That should be your last resort. Like, I have no fucking I can't tell what's happening. This person is freaky. I don't even know this is like, she's on, I'm handling the gallbladder. Here we go. Stop. I'll be back in 25 minutes. That's what those point prescriptions are for. They should not be the go-to. Well, okay. They shouldn't be the go-to. They should be the, I'm not quite sure. And I'd like to do something. So let's start with these. Okay, so the things that I think are useful for you guys to practice today, given that all of you are going to have varying levels of sensitivity, bodywork training, and practice feeling people. There's a good exercise, which I think is useful in cases like this. And it goes like this. You guys probably didn't bring them. I meant to send anybody have their dots from point location? Okay. If you have a fair, enough to hand out a little bit, you can also use a pen. You know, many dots. So the idea, the best way, like if I was to teach a class where our job would be to say, this is a practical channel theory class. The first class would be, your job is to, I don't want you to think so much about channels at all. And I absolutely don't want you to think about where points are. I don't want you to think about anything. I want you to put your hands on this person's body and put a dot where you feel something funny. I want you to say, I want you to start to, the only way to learn is to be like, okay, ideally we would have an agreement that you all know where channels go. We don't have that agreement. I don't know if you know where the channels go. I know you know a general trajectory, but I don't know if that's the case. So in that case, it's just better for you to just put your hands on folks and see, it's like, oh, just do this. Just take your paws and put them on their body and be like, well, yeah, that feels weird. Dot. Okay. That feels weird. The only way to, and then we come around and you have me check them. And I say, yeah, that's the liver channel. That's the third point on the liver channel. Notice the other dots you put on. Look at the pathway you're making. That's what all this means. Then we learn things together. We learned because you weren't thinking about, you weren't trying to tie something together. You were just using your sense. You have to, it's something you just have to, you have to do it. You don't know how hard to press. Sometimes points you get into them and it's like, they feel fine. And sometimes you get into them and they say, it requires a little bit more pressure. Like it's asking for it. Like if you're going to find something out about me, you got to inquire a little deeper. I'm not at the surface. I'm deeper. It's like, okay. And you find that. The only way you do it is just doing it. But initially you guys are going to be like, the focus cannot be on, this is the spleen channel. Let me check that. Don't even look down. Don't even feel at all what you're trying to feel for. Just feel. Put the dot. Make a mark. If it feels unusual, if the person, again, I'll come around and give demonstrations so that you can each have a sense of it. I'm in no way being, it's just light. It's inquisitive. I'm having a curious conversation. Think of it that way. My tone of voice is equal to my pressure. I'm just saying, what is this like? What is this like? How do you feel through here? Sometimes I find places that I'm like, hang on, I hear you down there, you're faint, and I need to get in a little further. And then I find the reactivity. Okay? So the only way to practice is to practice. And have some guidance while you're doing it. That's why you're in school, right? To learn new skills. But these kinds of skills aren't things that you need to have someone to bounce it off of. You need to have your fingers tell you something, and then have that be confirmed. Otherwise, you won't know. You'll just be like, I don't know. I don't know. You would learn if you were in practice, because you'd have your patients telling you. They'd be like, oh God, that hurts. Or that's really sensitive through there. And you'd be like, yeah, okay. Your fingers would reliably convey back to you every time. Yeah, it means this. Every time. It always feels like this. And all these people tell me that that's sensitive. And then you know. But you need to have some bodies moving through your day in order to have that. So in the worst case scenario, you'll learn nothing till you're done school. You'll start practice, and then you'll figure it out. That's not a bad worst case scenario. The other side of that is, if I had to say in cheering for where you guys are at, it's enough. It's a fruitful pursuit to be firmly rooted in the concepts of it anyway. Like, channel theory class would be a 1-year class. It has 3 parts. The first semester is just channels. You have to know where the channels are. You have to be able to demonstrate where they are on different bodies. On women bodies, on petite bodies, on big bodies, on flabby bodies, on toned bodies, on men and women. The only way you do that is by touching different bodies. You can't guess. You have to find them. And then you know where they are. That's semester 1. Semester 2 starts here. Now I know you know where the channels are. So, follow the channels and put dots on anything that feels unusual. Start at every channel. Doesn't matter which one you start with. Liver channel. Okay, liver 1. Let's go. Beep, 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 beep. How's all that feel? If it feels yucky, unusual, put a dot. And then it's checked. And then we talk about it. And by the end of it, you're like, yeah, okay, I got it. So in lieu of that, it had to be somewhat segmented. There's no reason why all of you on your own time, you have plenty of resources to learn where the channels go. If you're interested in double-checking that work, I don't have a good answer for you. I don't see many of you enough for you to ask me those kinds of questions. For those of you that I see enough, that's easy. You just say, I've been thinking, is this where this channel goes? And I'll give you my opinion. Yes, that is. No, it's over here. See? Touch people. Notice changes. Don't worry about points when it comes to clinic. Points are overrated. Everybody focuses too much on the points. There's no magic in the points. That's like going to the apple tree and saying, look at all the apples. These apples are magical. I wonder which one is most magical. They're just fucking apples. The magic's in the tree. The magic's in the process. It's in the mechanics of it. It's not in the friggin' fruit. So, I don't know what the plan is as far as breaks and things go.
But why don't we have a 10 minutes break, and then there are tables set up in the other room, and we'll just team up 2 or 3, and then we'll do what you suggested, filling and putting points on, and then you go around.
So when you come back from, you guys can, there's a table, I'm sure we can set up a couple more tables. Try to get in